Right. So everybody can put their names, name and surname, MP number, as well as their email address, if we don't have it already, in the chat box. If you send in your email address, we can also add you to our mailing list, and we also would know where to send the CPD certificate to. We'll probably bulk combine them when we've got enough together, and not send every month, because it's obviously a bit of administration to do. So today we are tackling a topic that I think doesn't come naturally to all of us, and I just want to say a big thank you to the team from Tygerberg Hospital. And I'm going to hand over to my colleague, Dr. Fatima Bassa, in a moment to introduce the members of the team. And also thank you to Dr. Jacques Malherbe, who will be giving us some exciting news at the end about a PNH clinical trial that is due to come to South Africa later this year. There is one ongoing as well. So we have 5 speakers, 90 minutes, and there will be time for questions, either in between or at the end, depending on how well we're making progress. But just to say, for those who don't know, PNH is a very rare condition, and to treat it is literally unaffordable in South Africa. The last time I checked, the price for annual treatment, which is, as you know, or some of you may know, ongoing and permanent, between 6 and 7.2 million rands per year, and you've got to take that treatment for life. So it's one thing to diagnose it, it's another thing to get the patient the right treatment, and that's why we're going to share something about the clinical trial coming up, so that everybody in the country will have the opportunity to refer patients for this clinical trial, because otherwise we've even found with the medical insurance companies, it's literally I think there may be 2 or 3 patients in the country at the moment on treatment that are getting it through their medical aids. With that, I am handing over to Dr. Fatima Bassa. Fatima is head of the Division of Clinical Hematology at the University of Stellenbosch, Tygerberg Hospital. I think we've known each other for more than 20 years. She's a fantastic colleague, lovely to work with her. We do a number of things together in the Western Cape in a joint fashion. It's fantastic to have such great colleagues and friends just other side of the river. And excited to have you guys here today, Fatima, and look forward to you and your team's presentations. Please go on, and you can start with the first one.
Yeah. Thanks, Vernon. And hi, can you hear me? Hi, Vernon.
Fatima, we can hear you. We can hear you.
Yes, ma'am.
Okay.
Yes, we can hear you.
Okay, thanks. Well, thanks for that introduction. And may I say the feeling's mutual. I really enjoy working with your team at Grooteskier. And I just want to say it's interesting that yesterday was Rare Diseases Day. It was celebrated across the world. So we are presenting this topic at an opportune time. As you say, it's a fascinating and complex disease that impacts on several systems and can actually make diagnosis pretty difficult, as you will note with our case that we are presenting later. I also want to welcome the Department of Hematopathology at Tygerberg, and I'm delighted that Tygerberg representation on the deep dive meetings is now complete. We have full representation from both clinical hematology and hematopathology. So we'll begin the session with Dr. Ethan Gantana, who's a hematopathology registrar at Tygerberg. And I thought it was appropriate to begin with an overview of complement-mediated disease and to see where PNH fits, because there are many other diseases that are impacted by complement. And this will follow by a discussion on the pathophysiology of PNH. Welcome, Ethan, and all the best.
Thank you, Dr. Bassa, and good afternoon to everyone. Thank you for this opportunity. I want to start by, there we go. I want to start by just going over the complement cascade and activation as an introduction. And shown on this slide here is the classic and lectin pathways of complement activation, which is similar in that the initiation proteins share structural homology. And more specifically, it's this C1q that shares homology with mannose binding lectin, while C1r and S share homology with the mannose binding lectin associated serine proteases 1 and 2. And for the activation of or initiation of the classic and lectin pathways, C1q binds to immune complexes that are formed on the microbial surfaces and mannose binding lectin to mannose. And this binding results in a conformational change of these molecules that then activate the serine proteases. In the classic pathway, the activated serine protease C1R then cleaves C1s, which is then responsible for cleaving both C4 and C2 to form the C3 convertase that then goes on to cleave C3 to C3b and C3a. The C3b then associates with what we already have over here, the C4b, C2a, to form the C5 convertase, which is the C4b, C2a, C3b. And it is then this C5 convertase then cleaves C5, and it's at this point where these two pathways, the classic and lectin pathways, converge with the alternative pathway to form the membrane attack complex. So this alternative pathway is an ancient pathway of innate immunity, and for this reason, the alternative pathway does not require antibody or prior contact with a microbe to function or for activation as with the classic pathway. And it serves as an independent immune system that is capable of recognizing and destroying infecting elements. So the alternative pathway is essentially always switched on, which is due to a small amount of auto-activated C3 that is always present, the so-called C3 tick over, and that refers to C3 hydrolysis, and this is due to the presence of a labile thioester bond. And in this way, the complement system constantly monitors and probes the environment. It is constantly trying its luck. However, this process is rapidly terminated in healthy human cells or in the fluid phase by regulators such as factor H that competes with factor B for the binding to C3, as well as very important regulators like the decay accelerating factor or CD55 and the membrane inhibitor of reactive lysis or CD59. And it is the absence of these proteins that are the basis of PNH. But I don't want to get ahead of myself. So the alternative pathway amplification normally occurs on foreign or damaged cells, and it's engaged when this constitutively activated C3 binds factor B, which then undergoes proteolytic cleavage as shown here at the top. And this cleavage of factor B is mediated by another serine protease, also known as factor D, to produce the smaller fragments BA and also BB. The alternative pathway convertase, which then consists of the C3BBB, is then stabilized by properdin, and as the C3 convertase cleaves more C3 to C3b, it then sets in motion this amplification loop, resulting in the deposition of large amounts of C3b on the target. The alternative pathway then engages the MAC when another C3b binds to the C3 convertase to form this C5 convertase. And this is because the binding of the second C3b shifts the substrate specificity from C3 to C5. And then the assembly of the membrane attack complex is the same as for the classical and lectin pathways, where C5b first forms a complex with C6 and 7 on either side, and then this is followed by C8 and then the C9 polymer that inserts in the biphospholipid membrane. So complement-mediated diseases, it's a very broad topic, and this is a table that is by no means comprehensive or all-inclusive of complement-mediated diseases, but I just wanted to give you an overview of possible complement-mediated disease and where PNH fits into all of this. So when we look at deficiencies in the classical pathway initiating proteins like C1QRS, they are associated with immune complex diseases, recurrent infections, deficiencies in the alternative pathway proteins like factor D and properdin can cause recurrent infections, and the same with deficiencies in the terminal pathway proteins that are responsible for the formation of the membrane attack complex. Deficiencies in the fluid phase regulatory proteins or the proteins that regulate the C3 and C5 convertases can result in recurrent pyogenic infections, immune complex diseases, and importantly, atypical hemolytic uremic syndrome, where the alternative pathway of complement is also activated. And then deficiencies in the membrane phase regulatory proteins like CD55 and CD59 are anchored by GPI anchors into the membrane, and the deficiency of these proteins are the mainstay of PNH pathophysiology. So in the next few slides, we will just have a look at why these regulatory proteins are deficient or absent on cells, on human cells. So there are generally two types of anchoring mechanisms for plasma membrane proteins, of which one is transmembrane. It's not shown here. And in this case, we are talking about GPI anchors. And this GPI anchored protein will consist of a phosphatidylinositol that inserts into the biphospholipid membrane, followed by a glucosamine that's represented here in orange, 3 mannose, and an ethanolamine phosphate. And the actual protein that's being anchored, represented in purple and in this figure, is the GPI anchored protein, or the GAP. And there are more than 20 GPI anchored proteins that's expressed on hematopoietic cells, including this all-important CD55 and CD59 that are important regulators of complement, as well as certain proteins that are important in fibrinolysis and anticoagulation that I'll mention a bit later. So the biosynthesis of this GPI anchor is affected in PNH, which leads to the deficiency of these proteins, or these very important complement regulatory proteins on the surface of these cells. And more specifically, it is this first step in the biosynthetic pathway that is affected, which is the transfer of the nucleotide sugar N-acetyl glucosamine to the phosphatidylinositol. And the reason why this first step does not happen is most commonly due to a somatic mutation of the PIGA gene on the short arm of the X chromosome. And this gene encodes for the N-acetyl glucosamine transferase that is responsible for transferring this glucosamine onto the phosphatidylinositol. And the majority of these mutations involve a frame shift that then creates a premature stop codon that results in a truncated protein product that is unstable and rapidly degraded. Unfortunately, the mechanism of this mutation is unknown. It's not been associated with specific mutagenic events. And theoretically, when we look at this image over here, PNH could result from the inactivation of any of the genes involved in the biosynthesis of this GPI anchor. But the reason why the PIGA gene has been, at least until recently, solely identified as the gene mutation in PNH patients can be explained by the fact that the PIGA is the only gene in the biosynthetic pathway of the GPI anchor that is located on the X chromosome, which means that a somatic mutation of only one allele is required for the expression of the phenotype. And for all the other autosomal genes, you will then require a somatic mutation of 2 alleles for the inactivation and therefore expression of the phenotype. So because this alternative pathway of complement is primed for attack with its always on C3 tick over mechanism, there are elaborate mechanisms put in place for self-recognition and protection of the host cells against this alternative pathway activation. And this means that normal human erythrocytes and also other cells like platelets and leukocytes are protected against this alternative pathway of complement-mediated cytolysis mainly by CD55, which is the decay accelerating factor that inhibits the formation and stability of C3 and C5 convertases, and the very important membrane inhibitor of reactive lysis, or CD59, which blocks the assembly of the membrane attack complex. But with the absence of these regulatory proteins on the surface of cells, the complement is activated, and you end up with membrane attack complex formation on the cells that lead to the lysis of these cells. And as PNH is properly characterized as a hematopoietic stem cell disorder, which is a result of clonal expansion of one or several hematopoietic stem cells that have acquired this mutation, any progeny of the affected stem cells, whether it is erythrocytes, granulocytes, monocytes, platelets, lymphocytes, etc., they're all deficient in all of the GPI anchored proteins that are normally expressed on these cells. So we know that PNH is a hematopoietic stem cell disorder. So for PNH to manifest clinically, the hematopoietic stem cell carrying this mutation, or the PIG-A mutation, must undergo clonal expansion. And there are various mechanisms in the literature and theories that have been described for the expansion of the PNH clone that I won't discuss in detail, but there's mention of things like immune escape, selective advantage for clonal expansion, and neutral evolution. So in the next few slides, we'll have a quick look at the consequences of the activation of this alternative pathway of complement, and therefore also the membrane attack complex formation on these cells. And the first and probably the most obvious one is intravascular hemolysis as a result of membrane attack complement complex formation on red cells. And when these red cells hemolyze intravascularly, they release free hemoglobin, they release arginase and procoagulant red cell microparticles, and these all play a very important role in thrombosis. But the release of free hemoglobin specifically leads to platelet activation, nitric oxide depletion or scavenging, endothelial dysfunction and activation, increased levels of tissue factor that activates the complement, activates coagulation system, and then also the complement, and increased levels of reactive oxygen species. And there are also some extravascular hemolysis as shown in this picture, because complement fragments coat the red cells that are then removed by macrophages. So thrombosis in PNH is a very important manifestation, but also very complex in its pathophysiology with many overlapping mechanisms. And this gentleman on the left here, Paul Strubing, was the first to suggest the link between PNH and thrombosis. But it was this guy, William Crosby, that was the first to describe the link clearly many decades later. So this is a very good summary from blood of all the various mechanisms of thrombosis in PNH, because I think it puts everything into context and clearly linking intravascular hemolysis with coagulation, as well as the coagulation cascade with complement activation. And this gray area over here represents complement and its activation, formation of C5, excess C5a, and the membrane attack complex. The red circle represents the red cells undergoing intravascular hemolysis, and then this green area shows coagulation activation. Now in PNH, we know now that the alternative pathway of complement is activated, that forms this membrane attack complex, as well as increased levels of C5a, and the assembly of MAC on red cells then results in intravascular red cell hemolysis with the release of free hemoglobin and then also red cell microparticles. And this free hemoglobin from the lysed red cells scavenges nitric oxide that results in vasoconstriction, and free hemoglobin also leads to endothelial cell activation with the expression of, for example, tissue factor. And we know that tissue factor is the primary initiator of in vivo coagulation. The procoagulant microparticles that are released from not only the red cells, but also the platelets and the endothelial cells further contribute to coagulation activation. And these microparticles are analogous to the procoagulant microparticles that we see in DIC and antiphospholipid syndrome. The membrane attack complex is formed on not only the red cells, but also the platelets that lead to platelet activation. And in addition to MAC activating platelets, there's also reactive oxygen species and thrombin from the coagulation activation that binds to protease activated receptors on platelets, and these activated platelets further contribute to coagulation. The excess C5a from complement activation contributes to this hypocoagulable state by binding to G protein coupled receptors on monocytes, endothelial cells, etc. And this results in the release of pro-inflammatory and pro-thrombotic cytokines that is responsible for cytokine-induced tissue factor expression. That then takes us back to coagulation activation. And with this increase in coagulation activation, there's also, in addition, a deficiency of anticoagulant and fibrinolytic factors, particularly those that are GPI anchored. And once this coagulation cascade is activated, the activated factors from the coagulation cascade can further contribute to complement activation. And this then starts this vicious cycle of complement and coagulant activation. Bone marrow failure is another important manifestation of PNH, and the causes of bone marrow failure underlying PNH is poorly understood and is most likely heterogeneous. Some articles suggesting that there is an immune component to it, but it does not seem that the PIG-A mutations directly give rise to the bone marrow aplasia, and instead it would seem that the underlying pathophysiologic process of aplastic anemia confers a relative survival advantage to PIG-A mutant stem cells, which then selects for the PNH clone. And the degree of bone marrow failure in these patients may vary from a clinical and laboratory picture that's consistent with severe aplastic anemia, while others may only have some reduced number of stem cells. Phenotypic mosaicism is the combination of different types of PNH cells that's present in an individual, which is characteristic of PNH. And in addition to having either a small or large PNH clone, the contribution of each phenotype to the composition of the blood varies. And this is clinically important because type 2 cells are relatively resistant to spontaneous hemolysis, and a patient with a high percentage of type 2 cells have a relatively benign clinical course with respect to hemolysis. But the most common combination in PNH is the type 1 and type 3 cells. And yeah, that is all from my side. Thank you very much for your attention.
Thanks, Ethan, for tackling a very complex topic. I must say I'm glad that you did it rather than me, because it's really quite hectic. Our next presentation is by Dr. Samira Irison. So she'll begin with a case presentation of a very interesting patient that was referred to us recently. And then this will follow by clinical features of PNH. So Samira, welcome.
Hi, sorry, I think some technical difficulties there. I hope everyone can see and hear me now.
Yes, we can, Samira, go ahead.
Thank you. Okay. So I will present a very interesting case that we have here at Tygerberg Hospital. So Mr. LG, he is a 31-year-old male who was actually referred to us from private, and apologies, but we actually had quite scant notes from the private sector. So most of the available history was just from the patient coming in and bringing a couple of referral documents. So from what we gather, he presented to a private gastroenterologist in November 2018 with very non-specific, unexplained severe abdominal pain. They had done a CT which demonstrated multiple filling defects in the portal vein and the hepatic veins. Of note, he also had a prominent portal vein collaterals, a borderline splenomegaly, but no evidence of cirrhosis or evidence of Budd-Chiari syndrome at this point. At some point, the patient was initiated on warfarin, again in the private sector, and then was subsequently referred to us in 2019 as a workup for thrombophilia by a private hematologist. Since we didn't have much history other than the fact that he was on warfarin and had these unusual thrombotic events, we started from scratch with him. So in terms of his history, he had a history of ethanol abuse, but had stopped in 2015. He didn't report any bleeding symptoms, no melena, and he had no symptoms of anemia or a prior transfusion history. He did admit that he occasionally did have episodes of dark urine though. In terms of his family history, he had no risk factors for thrombosis or thrombophilia, and he himself had no risk factors for thrombosis or prior known thromboses prior to these events that were detected on the CT scan. On examination, he was a well-looking young gentleman. He had a tinge of jaundice, mild pallor, and no clinical features of pulmonary hypertension. He had an enlarged spleen, no hepatomegaly, and no features of liver disease or abdominal wall collaterals. So these were results from some initial investigations. As you can see on the left, sorry. The patient had a pancytopenia, enormocytic anemia. The smear had showed a true thrombocytopenia, scant fragments, features of iron deficiency, also shown by a low ferritin, and no spherocytes. He had a raised RPI. The rest of his nutritional screen was normal, as you can see. In terms of his LFTs, I had mentioned he did have some jaundice. He had an unconjugated hyperbilirubinemia, a raised AST to ALT ratio, and quite a significantly high LDH. His haptoglobin was reduced. His Coombs was negative. He was also HIV negative, as well as the other viral screens were negative. And as part of a number of investigations, we found that his APLS screen was also negative. We did a bone marrow in view of the pancytopenia and these features. The bone marrow was markedly hypercellular, particularly erythropoiesis. He had normal number and morphology of his megakaryocytes. The granular poiesis was mildly reduced. Of note, he also, in keeping with the biochemistry, had absent iron stores. His cytogenetics on this were completely normal. We had repeated the CT. It showed splenomegaly as we had detected clinically. The portal vein was well opacified, so no filling defects. At this point, he had cavernous transformation of the portal vein. His liver, IVC, and hepatic veins were normal. But now, in addition, which wasn't seen on his previous CT, he had distal splenic vein occlusion with collateral veins. He, at this point, was still straddling private and the public sector. So we know that he had 2 endoscopies done in private. On following up in private, we know that he had esophageal and gastric fundal varices, and no intervention was done for that in September. We did an echo, and there was no evidence of pulmonary hypertension, and he had normal systolic function. So to summarize, a young Black male, not your usual thrombophilia phenotype, with multiple abdominal vein thromboses complicated by portal hypertension. He had a Coombs negative hemolytic anemia, and associated iron deficiency anemia, and pancytopenia. He had evidence of ongoing thrombosis and clinically significant hemolysis. At this point, with these findings, we thought the likely diagnosis was PNH. Due to the high risk for anticoagulation in view of his thrombocytopenia, so as I'd mentioned, he was started on warfarin in private. But when we came to us, in view of the thrombocytopenia, the possible bleeding from the esophageal varices and possible occult bleeding contributing to iron deficiency, we elected to stop his anticoagulation. I believe Dr. Nell is going to go into the flow cytometry, but it basically did confirm our findings with an 80 to 90% clone seen in our monocyte and granulocyte population. So an overview of PNH, an ultra rare disease often referred to as an orphan disease, 1 in a million literally. PNH clones are, however, found more frequently, as commonly as 15 per million people, but most of them have small, under 10% detectable polymorph clones, and unlikely will ever have significant disease. The median age of onset of PNH is 30. It has an equal male and female preponderance, and the median survival with supportive treatment alone, which unfortunately is the case for most of our patients, is 10 to 22 years. There's no known ethnic or geographic distribution. However, we do see certain phenotypes in ethnic and geographical lines. So the clinical features of this disease. So due to the rarity of the disease, the non-specificity of our symptoms, as I mentioned, this patient just came in with abdominal pain, they often have significant delays in diagnosis. The severity of this disease often correlates with clone size, but as Ethan mentioned, there are some exceptions. For example, if they have a predominantly type 2 type PNH clone, they don't have as severe hemolysis. So we typically talk about the clinical triad of PNH, so hemolysis, thrombosis, and bone marrow failure. So starting with the hemolysis. So there are direct symptoms. So the anemia varies depending on the PNH clone size, as well as your ability for a robust reticulocyte response. The hemolysis is often chronic and severe with periods of exacerbation. They can report Coca-Cola colored urine, which is worse in the morning, hence the name. Jaundice, the fatigue, which shouldn't be underestimated. It's often debilitating and disproportionate to the anemia, and often a result of multiple factors. They can also unfortunately develop renal insufficiency, which can be severe, either from acute hemolysis, there's direct toxicity from free heme, or from chronic hemolysis where hemosiderosis can cause proximal tubule dysfunction, scarring, and cortical infarcts. The indirect symptoms. So Ethan mentioned a lot about nitric oxide, and it is incredibly important in terms of the symptoms that they present with. The depletion of nitric oxide leads to smooth muscle dystonia. The GI system is preferentially affected for some reason, so often they do come in with abdominal pain, complaining of a very non-specific pressure sensation. Because of the dystonia, they can also have a dinophagia, erectile dysfunction, and pulmonary hypertension. The patient didn't have any history of erectile dysfunction or dinophagia, and we didn't see any investigations or clinical features of pulmonary hypertension. Thrombosis. So as mentioned, thromboses can occur in PNH, and as Ethan explained, it's an incredibly complex pathway, but incredibly important and the most common cause of death in PNH. It occurs in up to 40% of cases without treatment, and the occurrence of it is often correlated with the clone size and the degree of hemolysis, though it has been seen in smaller clones. In terms of what I mentioned about an ethnic geographic component, the Europe and US are more affected by thrombotic events as opposed to, for example, the Eastern countries. So it can involve, the thromboses can involve the arterial, the venous system, or multiple sites simultaneously. The table very nicely on the right shows just which areas are affected and how commonly. But the important feature is it's known to involve unusual sites. After they've had a thrombotic event, as Ethan had mentioned, that vicious cycle, they have an increased likelihood of subsequent thrombotic events. Budd-Chiari can be insidious or sudden, and the latter is often associated with a hemolytic episode. So simultaneous thrombosis and hemolysis. It tends to recur, and cirrhosis can eventually result. Some other areas that would lead to symptoms of splenic congestion, so hypersplenism, and splanchnic vessels, so bouts of abdominal pain, accompanied by mucosal ulceration, can also be a presentation in these patients. The cerebral veins are less often affected, but it can be insidious or catastrophic. The major venous sinuses are often involved, as I've mentioned, and the veins covering the cerebrum, especially the parietal area. The dermal veins can be affected, and the symptoms can range from mild erythema to purpura fulminans. Arterial thrombosis is less common and only seen in 15% of cases, but also can have devastating consequences depending on where it occurs. The bone marrow failure. So in these patients, bone marrow failure tends to dominate the clinical picture as opposed to hemolysis, which is an incidental finding. These patients typically have small clone size. As I say, clone sizes are more often associated with worsened episodes of hemolysis and increased risk for thromboses. The bone marrow failure may improve with immunosuppressive therapy, and then it may evolve to a more classic PNH picture with hemolysis and thromboses, but it's not believed that immunosuppressive therapy in any way increases the PNH clone. The bone marrow phenotype, contrastingly to the thrombotic phenotype, occurs more in Asia, Pacific Islands, and Latin America. It's important to know, however, that PNH is part of its own triad with aplastic anemia and myelodysplastic syndrome. And although these are distinct in their own right, they are interrelated conditions. So the clone size in the context of other bone marrow failure disorders, such as aplastic anemia and MDS, are highly variable. However, they tend to be small. The PNH clone in aplastic anemia, the PNH clone is seen in 50% of patients with aplastic anemia and a smaller proportion with MDS. It's important to follow up for the development of PNH in aplastic anemia. As I say, this can occur. Up to 40% of PNH develops from aplastic anemia. And then there are suggested time periods for following each of those up. There is no role currently in serially monitoring for the PNH clone in MDS. And so we have these three different pictures. The classical PNH picture marked by florid intravascular hemolysis, raised LDH, hemoglobinuria, a cellular responsive marrow, and a large population of a PNH clone. Then PNH in the setting of other bone marrow failure symptoms. Here, as I mentioned, the bone marrow failure dominates the clinical picture. The hemolysis can occur, but it's often minimal and just associated with abnormalities of the biochemical picture. The clone here, again, is small. And then subclinical PNH, often discovered incidentally in a workup for a patient, for example, with aplastic anemia. By definition, these patients have no clinical or biochemical evidence of intravascular hemolysis. Just to finish off our symptoms, always think of other causes for cytopenias. Iron deficiency is common in this hemolytic anemia, oddly enough, hypersplenism, and these are things that should also be looked for as part of your workup, not only an evolving aplastic anemia in the context of PNH. Inflammatory manifestations I've just mentioned here, though they're incredibly rare. And then leukemic transformation. So it's an under 5% lifetime risk, and it may arise from PNH or non-PNH clones. And for some reason, it's been described to evolve more to AML, especially pure erythroid leukemia. So I'm going to talk a little bit later about management, but I will now hand over to my colleague to discuss more about diagnosing PNH. Thank you.
Thanks, Amira, for that very clear appraisal of, again, a difficult aspect of PNH. I'd like to welcome Dr. Erika Nell, who's also a registrar in hematopathology, and she will present on the laboratory diagnosis of PNH.
Thank you, Dr. Bassa. So I am at HemPath at Tygerberg Hospital, and I will talk about laboratory testing for PNH. And as with most things in hematology, we start out with FBC, reticular cell count, and smear. And what we want to assess there is for cytopenias, as well as rule out other causes of hemolysis. So looking for fragments and spherocytes. Then we want to look for biochemical markers of hemolysis, and we know that PNH is a DAT negative cause of hemolysis. Like Samir mentioned, they get iron deficiency because of the loss of iron due to the intravascular hemolysis, and because this was a high folate, of high cell turnover state, they also get folate deficiency. But ultimately, the diagnosis of PNH is made on flow cytometry, and the rest of my presentation is going to focus on flow cytometry. But bone marrow biopsies with cytogenetics are also indicated if the PNH is suspected to be associated with a bone marrow disorder, or if we have a patient with classical PNH, which we suspect has an aplastic crisis, secondary to, for example, folate deficiency or parvovirus B19. So the clinical indications for PNH testing would be those patients that have chronic intravascular hemolysis that are DAT negative, for patients that have unexplained thrombosis, like in our patient that we are presenting today, particularly if the thrombosis is an unusual site and in a young patient and showing signs of either hemolytic anemia or cytopenias. I just want to draw your attention to the bottom text box now. In a blood article published in 2013 called Thrombosis in Paroxysmal Nocturnal Hemoglobinuria, they specifically discussed whether you don't have to investigate patients for PNH if they have a normal LDH level. And the conclusion is no, you should still screen those patients that are young with unusual thromboses for PNH, as they might have a small clone, or they might have a type 2 predominant PNH clone, which doesn't cause a lot of hemolysis, or they might be a heavily transfused patient. We should also screen patients that have evidence of hemolysis, that have dysphagia, abdominal pain, or erectile dysfunction, those nitric oxide phenomena. We should sign patients that have signs of hemolysis and an unknown cause of iron deficiency. And then we should screen patients with aplastic anemia, MDS, particularly patients with hyperplastic MDS, and patients with unexplained cytopenias. So flow cytometry for PNH. When we're doing flow cytometry, we are looking for the absence of a marker. So we know there are these GPI-linked cell surface molecules that Ethan told us about, and we specifically want to look for the loss of a marker. So because of this, flow cytometry is very technical. We don't want to be picking up random events of debris or broken cells. We only want to be picking up those intact cells that have lost their GPI markers. If we look on the left there, we see the red blood cells, we see CD55 and 59, which are those that protect against complement-mediated hemolysis that are GPI linked. And we can see that those are present on all cells, including all of the leukocytes. However, there are other markers that are more predictably and more reliably expressed on leukocytes. And therefore, we don't often use PNH flow, leukocyte PNH flow for CD55 and 59, but use other markers. Flow cytometry is also not performed on the lymphocytes for PNH because those have unreliable expression of the GPI-linked surface molecules. There's another method of detection called FLAIR, which stands for fluorescent aerolysin. And if we look at the picture in the circle there, we can see that FLAIR detects the actual GPI molecule. So unlike monoclonal antibodies, which detect the antigen that is linked to the GPI, FLAIR directly detects the actual glycosol phosphatidylate N-acetyl. Another concept to be aware of is that only mature white blood cells fully express GPI GPI-linked markers. So if there are precursor cells, they might not fully express those GPI-linked markers, and that could result in a false positive for PNH. For this reason, we test PNH, test for PNH by flow cytometry of the peripheral blood, but also to be aware that if there is a left shift or a leukoerythroblastic reaction, this would not give you a true result. So the monoclonal antibody and flare combinations that we have for flow cytometry, we do it in a two-step process. So first, we want to capture the target population using a non-GPI antibody to make sure that the cells that we are looking at are true. And then after that, we assess those cells for GPI deficiency using monoclonal antibody or flare combinations. I've highlighted or I've written in black there the most validated monoclonal antibody flare combinations as determined by the consensus guidelines for flow cytometry for PNH, which were published in 2018. But I've also included in gray there other antibody combinations or that can be used and validated in your lab as you might see fit. So for erythrocytes, they are captured on forward scatter and CD235A, and then we assess for deficiency using CD59. On monocytes, we capture them on CD45 side scatter, gating on CD64, and then we assess for deficiency using either CD14 or CD157 and flare. And then on neutrophils, we capture on CD45 side scatter, gating on CD15, and then assess for deficiency using CD24 and CD157 and flare. So for the erythrocytes, we're only assessing deficiency of one GPI-linked protein, CD59, but on the leukocytes, the monocytes, and the neutrophils, we need at least two markers to accurately determine if there is GPI deficiency, so that there is built-in robustness, because some of these markers can be lost, for example, just in MDS. The clone sites tend to be of similar size in the monocytes and the neutrophils, but they are normally larger than the clone size in the erythrocytes. And this is because the PNH clone is preferentially destroyed by intravascular hemolysis, and so it would not be representative of the entire clone. And also the erythrocytes might be diluted by transfusion. So the flow cytometry of our patient, we will use it as an example for flow cytometry. So the erythrocytes were captured using side scatter and forward scatter, and then they were a GPI deficiency was detected using CD59. We can see the type 1 cells on the right, and the type 3 cells, the GPI deficient cells on the left, and in between the two, we see the partial deficient cells, the type 2 cells. We can see that there were 9,999 events, and that the type 2 population was 12.9%, and the type 3 population was 11.4%. Importantly, we only differentiate between type 2 and type 3 on erythrocytes. We do not do the differentiation on leukocytes. For the leukocytes, they did side scatter and CD45. I say they, I'm so sorry, we don't do PNH flow here at Tygerberg Hospital, so I got these images from Grooteskier. So they do CD45 side scatter to identify the leukocytes, and then gating for the neutrophils are performed on CD15. And then for the monocytes, they identify it using CD33. And then even though only two GPI deficient markers are required to call it a PNH clone, at GSH they use 3 markers. They use flare, CD55, and CD66B for the neutrophils, and we can see that the deficient population accounts to about 88%. And then for the monocytes, they use flare, CD55, and CD14, and then the population there is about 89%, so those are very comparable. The number of events, there were 7,300 neutrophils and 404 monocytes. And I only mention that because we will speak a little bit about the number of events just now. We'll talk about some technical aspects of flow cytometry now. So when can we classify a population? Can we just count the random events as PNH clone, or is there some kind of a minimum? And this has been defined for us as a minimum of 50 events to call a cluster of events a PNH cell clone. And so because there is this minimum of 50 events, the sensitivity of our flow cytometry will be determined by the number of events that we can that we have in a population. And this isn't the number of events in total for the flow cytometry, but rather for each population. So for the red cells, for the neutrophils, and for the monocytes. And so if we have 5,000 events, this gives us a sensitivity of 1%, which by technical standards is a low sensitivity flow cytometry, but it is satisfactory for the diagnosis of classical hemolytic PNH. 50,000 events will give us intermediate sensitivity. And then for high sensitivity flow cytometry, we need at least 500,000 events. And this high sensitivity flow cytometry is required for the identification of small PNH populations that are often associated with bone marrow failure disorders. So when we're setting up our flow cytometry for PNH, there are some things to be aware of, and depending on the fluorochromes and the conjugates that you are using, you need to be aware of the limitations of those. So the first thing is that not every fluorochrome works for every marker. For example, anti-CD59 works better on PE than it does on FTSE. So you get better separation between type 1, type 2, and type 3 populations if you use the PE fluorochrome. Additionally, CD235A works better on FTSE because FTSE is negatively charged, and then you get fewer aggregates than if you put 235A on PE. So the negative charge kind of repels those aggregates. And as we can see in the image on the right, they gated across the singlet red blood cells and they excluded the aggregates on the top right. And then if that was a 235A PE fluorochrome rather, there's likely to be way more of those aggregates. The second thing is that not all conjugates are made equally. So just because we have a CD59 on PE doesn't mean that if you buy it at BC or Bioscience, they're going to be exactly the same. And we can see on the top panel that this OV9A2 allowed for beautiful separation of our type 1 and our type 3 populations. But when they tested the same patient's blood using this other conjugate 1F5, then there was poor separation and almost bleeding of the type 1 cells into the type 2 gate, which would give you an inaccurate population size. And the consensus guidelines have stated for us each of the conjugates which give the correct PNH clone sizes, both for red cells and for leukocytes. And then some capture antibodies are better than others. For example, if we were to use CD45 side scatter to capture our neutrophils, then what would happen is basophils and NK cells would also be captured in those. And when we test them for the GPI deficient population, for example, CD24, those cells naturally don't express them. And you would falsely call those PNH cells, but they're actually just the wrong cells. And then in terms of CD33, the gating of neutrophils is actually better with CD15 than CD33 to gate neutrophils. Platelet aggregates might mimic PNH if we use CD33. And also CD33 becomes very difficult in conditions like PNH. And so the more technical and the higher sensitivity flow that you are running, the more important it becomes to think about these kinds of considerations. And for monocytes, again, CD64 is better than CD33. Basophils can also fall into that CD33 gate and mimic the PNH clone. FLAIR is a Alexa 488 conjugate. And though it has a similar emission spectrum as FTSE, the settings aren't comparable, and you actually need to set up the flow cytometer specifically for an Alexa 488 fluorochrome and not just use the FTSE settings. And finally, a viability dye can be used to exclude dead and apoptosis cells. I'm going to reiterate that we're looking for the absence of a marker as opposed to the presence of a marker. So it's very important that we're not picking up dead cells. And the one way that we try to reduce this is by making sure that all samples are fresh, less than 48 hours since the blood was taken. And another way is to use these kinds of viability dyes. The example over here is DRAC7. And if we just look at the neutrophils, we can see that between type 1 and the type 3 population, there's this 1.4% that's kind of hovering in between the two populations. And when they used the viability dye, then that was reduced to 0.7%. So it improved the separation between the two populations. There's also a standardized way of reporting. So if we have a clone size of more than 1%, then we can clearly state that there's a presence of a PNH clone, and we need to state the cell lines. We can call it a population if it is present in 2 cell lines. So typically that's either neutrophils and erythrocytes or neutrophils and monocytes. And then the clone, if the clone is 0.1 to 1%, then we should state the presence of a minor PNH population in report the cell lines, and then also state that the clinical significance of this is uncertain and to repeat it in 3 to 6 months. And then finally, if the PNH clone is less than 1%, then to report it as rare cells with GPI deficiency. Again, the clinical significance is uncertain and they should repeat the flow in 6 to 12 months. On the report, the sensitivity of the assay that was performed should also be stated as 1%, 0.1%, or 0.01%. And importantly, if the sensitivity is more than 1%, i.e. we didn't get 5,000 events, and there is no PNH population that could be detected, that it should state in the report that a PNH clone cannot be excluded. Thank you. Back to Samira.
Yeah, so thanks, Erica, for that very clear presentation. And I can see that everybody's understood it well because there's no questions in the chat box here. Okay, so the penultimate presentation is by Samira Irison again, where she will discuss aspects of management of PNH.
Right. Thanks, Dr. Bassa. I hope all of you are still with us. That could be the other reason for no questions, but I will try and keep this brief because I think Dr. Malherbe has far more exciting news. So back to what we were discussing before, the management of PNH is often based on the disease classification, so the phenotype of the patient. Subclinical PNH, the therapy should focus on basically the underlying bone marrow failure syndrome. If they predominantly have a bone marrow failure syndrome, they may benefit from immunosuppressive therapy, but large clones can also possibly, there's a role for eculizumab. In classical PNH, without question, the first line is to treat with eculizumab. If you have an inadequate response, then there are things that could be added, and I'll speak to that now. So the supportive treatment that we use, iron supplementation, as I said, these patients can often have iron deficiency. Replacement can be associated with worsening of the hemolysis, particularly if the IVI preparation is used. However, if a patient needs supplementation, this shouldn't be a deterrent. Contrastingly, in the presence of eculizumab, they may in fact need iron depletion therapy, which I'll speak to in a moment. As with most chronic hemolysis, folate is good to support the stress marrow. Transfusions as required may also suppress erythropoiesis, which may have an additional advantage. Opioids, especially for the debilitating pain. Then splenectomy, the role's unclear. It is actually mentioned in that 2011 guideline. There is unfortunately only anecdotal evidence of decreased hemolysis and cytopenias. And then of course there's the increased risk of post-op complications, including thromboses. So this isn't an option that we consider at Tygerberg at least. Those who are asymptomatic or have mild symptoms are actively surveyed, and their FBC, LDH, and reticulocytes can be monitored to see if they do in fact develop more severe symptoms. I put question marks next to steroids and androgens because post-eculizumab, the role for these agents are somewhat uncertain. I was disappointed when I went on PubMed and typed in PNH and steroids or androgens. I got about 3 results, and most of them predated 2000. Unfortunately, in the third world, this is the reality of what the mainstay of treatment is for us. So the guidelines say that steroids have a debatable value, and some members of the PNH interest group don't recommend its use under any circumstances. Once again, this is with access to eculizumab and better therapies. In our reality, that's not the case. It has value in the acute setting, so brief pulses often attenuate the acute hemolytic exacerbations. And its chronic use does have evidence of modest improvement, so not normalization, but improvement in 3 cell lines, with reduction in hemolysis seen in a variable patient population. The side effects are, of course, quite severe with chronic steroid use. And there's been a suggestion for alternate day schedules in these patients who have severe side effects to attenuate some of those adverse effects. Similarly, androgens are not recommended or rather have questionable evidence in the eculizumab era. However, we know that alone or in combination with steroids, they're very useful for anemia, especially if there's a hyperproliferative component. And we know that danazol has usages in our bone marrow failure syndrome. So alone or in combination can be used. One must often worry about the complications though. So virilization, prostatic hypertrophy in men, and then liver toxicity. But as I say, in the absence of better treatments, this is often our options. So what you'll find in most guidelines is the focus on eculizumab, and rightfully so. It is completely changed the landscape of PNH management and revolutionized patients' lives. So looking back at how Ethan had explained the complement pathway, if you look at the terminal aspects of complement, eculizumab is a C5 inhibitor. So in essence, prevents its conversion to C5b and then terminal complement activation. Candidates for this treatment, so those with large clones, often that does correlate with symptoms, so that makes sense in terms of our guidelines. Those with good reticulocyte response and high LDH are most likely to respond, LDH indicating our degree of intravascular hemolysis, while the reticulocytes, if they're raised, indicate a robust bone marrow response. So patients who are more on the side of classical PNH. The symptoms, which again should not be underestimated, so debilitating fatigue, dyspnea, and frequent pain paroxysms is also an indication. And then, of course, worsening renal failure and thrombosis. So the 2 landmark trials in terms of eculizumab's efficacy are the TRIUMPH and the SHEPHERD trial. Just to summarize the immediate findings, there was improvement in the HB levels from 9.3 to 10.2, decreased transfusion requirements with transfusions almost ameliorated completely in some, decreased measures of intravascular hemolysis, and subjective increase in quality of life. Additionally, there were no deaths or serious adverse events related to this therapy. Long-term, improved transfusion requirements, decrease in hemolysis, and long-term sustainability of this on long-term follow-up. They saw that fewer patients experienced VTEs while on eculizumab than those prior to initiation. Renal function improved or stabilized in 93%, and in fact, renal failure doesn't even change the dosaging for this drug. Often it improves, if anything, the renal failure. And there's no evidence of cumulative toxicity over time. So great evidence for this drug. Some disadvantages. 1, the HB response can be variable. So we saw that there wasn't quite normalization. This can be due to coexisting conditions. If there's bone marrow failure, for example, or other inflammatory conditions. Genetics play a role. The degree of extravascular hemolysis, which is actually one of the complications that I'll have to talk about, and the size of the PNH clone after therapy. It also has no effect on bone marrow failure, again, why it's not a primary indication, and has no effect on the development of clonal myopathies, which can occur in a small percentage. The problem, the main problem, as Prof. Lowe has mentioned, is that this is incredibly expensive. The price tag, this is the financial indices in November 2020, $6,500. If you think about that, 4 times weekly, and then for the rest of your life, 900 milligrams. I think that the total for a patient is baffling, and especially if you try and convert that to rands, I don't think most of us would be able to comprehend that figure. And I don't think medical aids routinely would swallow this either as a bill for a patient. So in our country, it isn't yet a reality at these prices. Important to remember that they need meningococcal prophylaxis. So with terminal complement inactivation, they are at risk of Neisseria meningitidis, and vaccination is recommended. I've spoken a few times about the extravascular hemolysis. So this is a terminal complement inhibitor, but C3 convertase is not inhibited. Thus, you have accumulation of this and degradation products that accumulate from the red cells, so the C3b deposition, and that itself is an opsonant, so something that is cleared by the reticular endothelial cell, the reticular endothelial system, sorry. So that deposition can then lead to an extravascular hemolysis. And this is just the mechanism. Once again, it's a tough pathway to remember, but we have here the accumulation of C3b depositing on the red cells, and then once again being taken up in the reticular endothelial cells. So despite the rarity of the disease, there are quite a lot of things that are being worked on in terms of trying to create targeted therapy. We have been speaking about the C5 inhibitors, but as you can see, there are multiple targets along the way. So the other C5 inhibitor that's also getting some buzz is ravulizumab. It's a second generation, longer acting C5 inhibitor. It virtually has the same efficacy as eculizumab, but has a longer half-life, and thus permits maintenance every 8 weeks, which makes it modestly more affordable, but still pretty unaffordable. C3 convertase inhibitors also in development, and then looking at inhibition earlier in the pathway, the factor B inhibitors, and importantly and excitingly for us, factor D inhibitors. So factor D inhibition, just to speak a little bit about it, is the rate limiting step in the alternative pathway. So it's quite an attractive target for that reason. It catalyzes the cleavage of factor D, leading to C3 convertase, and thus has the possibility of using both intravascular and extravascular hemolysis due to that C3 opsonization that I mentioned. And very attractively, unlike the C5 inhibitors, is available as an oral formulation and being available as a trial in South Africa. Just for completeness sake, outside the options of a trial, stem cell transplant remains the only curative option. It's recommended that it's you need an allogeneic source. Non-myeloablative regimens do reduce the morbidity and mortality. However, that remains still quite high. And bone marrow stem cells rather than a peripheral blood stem cell source is preferred. The limitations are the lack of matched donors, as well as I mentioned, the high morbidity and mortality. The study I mentioned at the bottom reported a 5-year follow-up mortality of close to 30%, so a third of their transplant patients. The indications, though, would be bone marrow failure, recurrent life-threatening thromboembolic disease, transfusion-dependent hemolytic anemia, and PNH that's unresponsive to eculizumab or not available. As I mentioned, the outcomes are variable, with an overall survival of 50 to 70% long-term. Just to speak briefly about PNH and thrombosis, so in the acute event, it's recommended that one treats conventionally, so low molecular weight heparin transitioning to a vitamin K antagonist. There isn't sufficient evidence to recommend the DOACs, and so they are not recommended for the management of PNH and thromboses. If it's a life-threatening thrombosis and the patient also has thrombocytopenia, a platelet transfusion to allow anticoagulation is advised. Eculizumab, once again, is indicated that should be started as soon as possible as secondary prophylaxis. But if you have no access to eculizumab, or if you plot on eculizumab, which is unlikely, lifelong anticoagulation is the recommended course. Thrombosis is a unique problem in PNH, in that thrombocytopenia, as with our patient, can be a feature which increases their bleeding risk and can be sometimes difficult to maintain a therapeutic INR. In terms of primary prophylaxis, still controversial and debatable. There isn't high quality evidence to recommend it. One needs to take into account your patient's bleeding or thrombotic tendencies. There may be a benefit for low molecular weight heparin in the short term of a hospitalized patient, for example, at a hypercoagulable risk, so undergoing surgery or something of that sort. And antiplatelet agents are again controversial. So back to our patient. So he came to us and shortly thereafter had an acute exacerbation of his hemolysis, which was quite recently actually in November. And he did require transfusional support and high-dose prednisone. As I said, not routinely recommended, but our patient did quite well with it. He remained well clinically, and he, on biochemically, we can see as a compensated hemolysis. He has no new clinical obvious thrombotic events. So currently where we are with him is hematinics because of the iron deficiency, his prednisone, which is slowly being weaned, and propranolol for his portal hypertension. Later this month, we're going to book a repeat bone marrow because his thrombocytopenia does appear to be worsening despite him now being iron replete. And then the next phase for him, or the next hope for him, is to secure a trial spot. So we unfortunately weren't able to get him into the phase 1 clinical trial, but hopefully there's a chance to recruit him into another trial. So yeah, these are my references. They're at the bottom of the slides as well. But UpToDate also has a nice summary of everything. So I'm going to hand over to Dr. Malhar, who will tell us more about the trial. Thanks.
Good afternoon, everyone. And thanks again to the Tigerbird team. I really enjoyed your presentations. It was excellent. So I'm just going to share my screen.
Thanks, Jacques.
Can everybody see my screen?
Yes, we can. Thanks, Jacques.
Yes, we can see.
So we've had the privilege to be in one of the 2 sites in South Africa for the phase 1 BCX9930 trial from BioCrest. It was myself and Andrew McDonald in Pretoria. And interestingly, between myself and Andrew, we were able to recruit globally all the C5 inhibitor naive patients onto the trial. He recruited 6 and I recruited 4 patients. So the slides I'm sharing is actually the public update that's available on BioCrest's website. It's a little bit outdated. It's the September 30 update of last year. There's apparently another data update is due in the next 2 weeks. So if you're interested, you can look on the BioCrest website in about 2 weeks, and there will be an update on this data. So yeah, BioCrest, I'll just maybe just for interest start off with that they're quite a small company. They tell us they're not profitable yet. They're reliant on Wall Street investors at the moment, but so they've got quite a few drugs in the pipeline, mainly for rare diseases. They've also got the BCX9930, which is the oral factor D inhibitor. They've got an interesting antiviral agent, galidesivir, which is initially developed as a hepatitis C antiviral, but now in trials for Ebola, Marburg, and Zika. And then lately also as a COVID-19, there's in Brazil, they've got some trials in COVID-19 for galidesivir. And then Orladeyo is the only currently approved drug is berotralstat, which is a drug for hereditary angioedema. And then they've also got a ALK2 inhibitor, which is for fibrodysplasia ossificans progressiva. I've got no idea exactly what that is, but it, yeah, sounds like a rare disease. So just to, the slide just shows where they are targeting BCX9930. I think the previous speakers very elegantly explained the complement pathways and the different treatment options. And Samira mentioned that factor D is the rate limiting enzyme in the alternative pathway, and is a very attractive target. And it essentially prevents the formation of these opsonins, which with the idea to limit extravascular hemolysis, and obviously also limiting the formation of the membrane attack complement and abrogating intravascular hemolysis. So the different diseases where they are looking at trialing this agent is obviously PNH was the first target, but also atypical hemolytic uremic syndrome, lupus nephritis, ANCA-vasculitis. There's a few nephrology conditions, C3G glomerulonephritis, primary membranous nephropathy, and IgA nephropathy. So it'll be interesting to see over the next few years where, where this would be successful. So that's their selling point, is that as the oral monotherapy offers advantage of controlling both extravascular hemolysis. So obviously relieving anemia, reducing PNH symptoms, and I think I can't stress enough this. We tend, as hematology, we tend to focus on the anemia and cytopenias, but even what I noticed with these patients on the trial is once they're on the agent, you actually then realize how much debilitating symptoms they had. It's something that we don't ask about, things like erectile dysfunction, episodes of abdominal pain, and fatigue. So this phase 1 trial was a proof of concept study. It was a dose ranging study initially. Cohort 1 was 4 patients that started on a low dose, 50 milligrams BD, then escalating to 100 milligrams BD. Cohort 2 was 200 milligrams. At this data cutoff, there were 3 dosed in that cohort, and then increased to 400 milligrams BD. There's been further dose increases subsequently. And then after the initial trial period, patients go onto an extension phase if they benefit. So the patients needed to be anemic or had blood transfusions in the last 12 months, had to have a raised LDH, PNH clone size more than 10%, and a platelet count more than 30, and a raised reticulocyte count. So this is just a table summarizing the patients that were enrolled at that point. And they all had markedly raised LDHs. Some of them had impaired bone marrow function. There was some of them had a history of pulmonary thrombosis, pulmonary hypertension, or renal injury. And then this is just to show the dosing. They all went through the different dose escalations, and based on persistently raised LDH in the first 2 doses, 50 and 100 milligrams, most of them, or all of them actually, were eventually escalated to at that stage, the maximum dose of 400 milligrams BD. And one could see here that there's really been a dramatic response. And so the hemoglobins increased dramatically, and quite rapidly. And one thing that one of our patients had a slow rise in hemoglobin because of an underlying iron deficiency that was embarrassingly missed due to the intravascular hemolysis. So the moment his iron were replaced, his hemoglobin started rising. And there was a significant increase in baseline of 3.8 grams per deciliter. And then just to sort of correlate that with the LDH, the hemoglobin goes up, the LDH goes down. There was a breakthrough hemolysis in this patient. It wasn't my patient, so I can't remember the details of why this patient had breakthrough hemolysis. But one can see as the hemoglobin goes up, the LDH goes down. And then just to note about the symptoms, and this is something that I noticed very quickly, is these patients within the first week or two were saying they've never felt better since their diagnosis. The first thing that one of our patients reported was his complete resolution of erectile dysfunction, and he begged us to never take him off the agent. Their fatigue improved, and their general symptoms were what the patients noticed first. And in terms of the safety, so far there's no discontinuation due to adverse events. There were no drug-related serious adverse events or safety signals. Although we had our first enrolled patient, this is actually the first patient that got this drug ever in the world. A patient of mine who had PNH for 8 years, and he was a professional nurse. And I've managed him over the years with steroids and danazol and azathioprine and he actually managed to maintain his hemoglobin to a reasonable degree and continue on working as a professional nurse. But he had significant symptom burden throughout this period, even though his hemoglobin was normal. And he had a dramatic response to the agent. And then after the 28-day period, he called us to say that he noticed a rash. And this turned out to be varicella infection. And he had the most rapidly progressive fulminant varicella hepatitis that was actually fatal. So quite a dramatic event. Obviously created great concern and investigation on behalf of the sponsor and us, and extensive literature review and scientific review. There's been no reported complement deficiency is not seen as a risk factor for viral infections. And it seems like, but long-term steroid use and immunosuppressants such as azathioprine is certainly a risk factor. And incidentally, neither the patient nor his sister, who's also a nurse, ever had chickenpox as children. And it just was a bit of a wake-up call for me that our patients on long-term steroids, we should be thinking of these things, and if they've not had chickenpox as children, or they're not immune to varicella, we should be careful and actually educate them to, if they do present with any rashes that's suggestive of this, they must call us immediately. There was, unfortunately, he delayed about 2-3 days before he informed us of this, and I think that contributed to his fatal outcome. So unfortunately, in the trials, there's now a exclusion for patients on chronic steroids, and all patients need to be vaccinated against varicella due to this adverse event. But otherwise, the drug has been very well tolerated. So currently, unfortunately, Fatima was trying to get their patient onto our trial, and he just missed the cutoff that by the time we were consulted with him, the phase 1 trial has recruited all patients. But the phase 2 registration trial is definitely coming to South Africa, and there's 3 sites. It's myself, Andrew again, and if I understand correctly, also UCT will be a site for the phase 2 trial, which will be the initial bit will be a against placebo, the BCS 9930 against placebo, and then they switch over to active phase, and all patients go on to active treatment. Initially, I was a bit worried about the inclusion criteria, where the platelet cutoff was 50, and many of our patients would then not be eligible, but they've listened to sort of feedback and reduced the platelet cutoff to 30. So I think, yeah, hopefully the sort of expected recruitment is by July. So if you have patients, contact us, and hopefully we can assist with the patient that Tigerberg presented somewhere on the trial. But so far the experience has been very good. It's been fascinating to be involved in a phase 1 trial, and all the discussion around everything is scrutinized in the greatest detail, and it's been a fascinating experience. And with that, I'm done with my story.
Thanks, Jacques. I'd just like to say a very big thank you to you for agreeing to come on board, despite the fact that you were on leave for a very special event. So this is much appreciated. May I just ask about 3 of the patients that had compromised bone marrow function? So were they aplastics?
Yes, so they were, all the patients that I enrolled were patients with previous aplastic anemia. Most of them were treated previously with ATCAM and cyclosporin in years gone by, and then later on developed hemolytic PNH with sort of relatively preserved bone marrow function. The others were on so they were either previously treated or they were on danazol to sort of maintain counts. So it is possible to recruit as long as they reach the cell, the platelet and neutrophil cutoffs at screening. They are able to enroll.
Okay, thanks. And Vanna, may I ask if you at Grooteskier have had any patients for allogeneic transplant, those with PNH?
Thank you, Fatima. I think I've got to refer that question to Estelle or Cecile, because I don't think we've transplanted anyone that I can remember since I've joined the team in April of 2018.
No, we transplanted a patient, I think the year before.
Yes.
And he had hemolytic crisis, and as far as I know, he's doing quite well. Perhaps one of the fellows who saw him last can chime in, but it worked well.
Thanks.
It worked well. Though he's not the most guy who follows up very regularly, but it worked, yeah.
But isn't that a good thing if people don't have to follow up regularly?
I hope it's good. Yeah, I hope it's good.
I mean, I for some reason came across his folder the other day, where he knew he had to come back to us. We had diagnosed him with this disease. He was actually in George, and he went back to them again, and he had pain, and they gave him NSAIDs because he had pain, and he then had a terrible kidney insult because he had hemoglobinuria, as well as was given a lot of NSAIDs by doctors that didn't know him. So he was a little naughty.
Yeah, sure. And I think there was one a longer period ago, with a very long time ago, which was also successful, but I can't recall. About 2 that I know of. Yeah.
Great, thanks, Cecile and Estelle. Fatima, I see Dr. Mike Tutue, one of the fathers of hematology in South Africa, has got his video on, and when that happens, I'm always curious and very keen to hear what he's got to say.
Yes, let's go ahead. Hi, Mike.
Hi there, greetings.
Hi, Mike.
Thank you very much. I enjoyed the presentations very much. I thought I'd just add that we had a patient quite some years ago, probably 10 or 12 years ago, with a good going PNH, who we tried all those other measures that Jacques has been mentioning. We eventually transplanted him, and he did extremely well with the transplant. got back to a very complete full life. He had been a professional diver before then, but he got back to a very full life. And then about 7 or 8 years after the transplant, he presented with an acute myeloid leukemia, which was aggressive, refractory, and he died from that. So he was very well for a time, but he did eventually develop a leukemia clone. There was something else odd about it, which I can't remember off the top of my head, but that was the experience I can remember.
Thanks, Mike.
Well, you transplanted him a second time, Mike, and it worked for a few years. I think that was the odd thing. And then he relapsed again.
I think that's right, yeah.
Yeah, so
Yeah.
you actually gave him another few years
I do.
of good quality life, and then
Oh,
the disease came back.
I think we transferred him to you, didn't we? For a bit. I think you transferred to Grootskeer for a short while. Anyway, I think the patient came to Grootskeer because he couldn't afford the third transplant. I can't remember exactly what happened at the time of the transplant, but somehow Grootskeer was involved. That's why I think you remember him.
Yes, his medical aid, was a problem at that stage because the poor man couldn't work anymore, obviously. And he, as I said, he had a second successful transplant that lasted a few years, but then he relapsed again. And I mean, that's when we had him. So a very tragic story, actually, but also a big success story. We don't live forever. So he actually had a beautiful 10, 12 years.
So it's like that school report. It does well, but could have done better.
Wonderful. Fatima, I noticed there's a question in the chat box. I don't know if you saw that one from Yaglin.
No, I didn't. I missed that one. Sorry.
So he says, I can quickly read it for you, Fatima. Oh, you got it?
Yes, thanks.
Okay,
Yeah.
great.
So it's a patient with thrombocytopenia of 75 and a PNH clone of 5%, normal LDH and D-dimer, no history of thrombosis. Should patient be on anticoagulation? And if yes, what would you recommend? Is there a role for pulsed anticoagulation in high-risk scenarios? So I would like to know what the bone marrow showed in this patient. Yekelin? Because if he has a normal LDH and a PNH clone of 5%, so what is the cause of his thrombocytopenia?
Hi, Fatima. Thank you. The bone marrow showed reduced megakaryocytes.
Yeah.
All other lineage lines were preserved.
And was he having active hemolysis? Because his LDH is normal, which is very unusual for PNH. And was he having thrombosis?
No, it's a female. She presented with uncontrolled hypertension, incidental finding of thrombocytopenia. So we started working up for ITP. Initial bone marrow only showed reduced megakaryocytes. Subsequent investigations identified a 5% PNH clone.
Yep. Because for me, a significant PNH is not on the cards because the clone is quite small. There's a normal LDH. I'm not sure what the hemoglobin and haptoglobin was.
All was normal.
Yeah, so then I wouldn't anticoagulate this patient, especially since you're dealing with a thrombocytopenia. I know it's 75, but if I was pushed, I would probably consider it in a high-risk patient.
Okay.
I hope that answers your question.
Yes, thank you.
So I think that brings us to the end of the formal presentations. I'd like to thank the Tigerberg team for a very well done presentation, as well as to all the attendees for participating and making the presentation very worthwhile.
Yes, I just want to say a big thank you,
Bernard,
Fatima, and your whole team for a wonderfully prepared and presented set of presentations. It was really, really great. I can see that the quality of this meeting is just improving. We hit a high of 77 people at one point today, which I really thought we would not have due to the rarity of the disease, but clearly the interest and excitement in hematology is just growing. I want to advertise next week. That will be Jacques and his team from Bloemfontein that will be speaking to us on primary myelofibrosis. And we're looking forward to that. But then I also want to quickly share my screen and just give you a heads up of what is happening the week thereafter. And I promised that we will have some international experts this year. And we've already got a couple lined up. I'm not going to give it away right now who they are, except to say that Prof. Robin Fua, who is an absolute legend in the field of hematology, a past president of the of EHA, amongst other things, and somebody with an immense experience will speak to us on Monday, the 15th of March. And I asked him specifically to talk on his experience, you know, to contextualize CLL and the treatments and the diagnosis as part of the history thereof, to show us how things develop, because he's one of the few people that have been around the block from the beginning or from the early days. I think it's going to be really fantastic. So please diarize that date. I know you diarize for every week, but I think invite people for that one in particular. So we'll send out the invites closer to the time. And yes, start taking, recording, making a list of the names of your PNH patients. As Jacques mentioned, we plan to have the 3 centers, one in Gauteng, Free State, and Western Cape, Groote Schuur, Bloemfontein, and Andrew McDonald Center. Please start noting down who those patients are that you may want to refer to your nearest center. And we'd love to see if we can help this very special group of patients. With that, have a lovely week, and we'll see each other again next week. Thank you. Bye-bye.
Thanks, Wanda. Somebody